This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Thank you for joining us today for our HealthyU webinar series on understanding sciatica. Please enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many as we can within the time allotted. I'd like to introduce you to today's presenters, Dr. David Ben-Eliyahu and Dr. Brian Durkin. Dr. Ben-Eliyahu is the Administrative Director of the Back and Neck Pain Center at Mather Hospital and the Director of the Mather Chiropractic Collaboration Program. Dr. Ben-Eliyahu is a chiropractor and has been in private practice in Selden, New York for 34 years, where he directs an integrated and collaborative spine and musculoskeletal practice. Dr. Brian Durkin is the director of the Pain Institute of Long Island, with offices in Woodbury, Riverhead, and Port Jefferson. He is board certified in pain medicine and anesthesiology and has a clinical interest in back pain. Dr. Durkin is the former director of the Center for Pain Management at Stony Brook University Hospital. Dr. Ben-Eliyahu?
Thank you. So today's webinar is going to be on a very common diagnosis that we see in clinical practice called sciatica. And sciatica refers to leg pain, and that's what we're going to talk about today. Next slide. So as you can see, the anatomy of the sciatic nerve, which is one of the largest nerves in the body, is formulated by a bunch of nerves that come out of the lower back. Looking at the picture on the left, which is right here, that's the long sciatic nerve that comes down the leg. So very common, patients will experience and people will experience pain that sometimes is in the lower back, but predominantly in the leg. Patients can present with both back pain and leg pain. They can present with just leg pain only, which is very, very commonly seen in clinical practice. So a pinched nerve here in the lower back can obviously cause a compressive phenomenon that can cause referred pain all the way down the leg. And some people will feel it in the buttock, some people will feel it in the thigh or calf, and some people will feel it in all areas. And it's very painful. It can be associated with numbness and weakness, and it has multiple causes, which Dr. Durkin is going to review. Next. So sciatica is simply pain in the leg, as I said before, and it can be caused by herniated discs. It can be caused by spinal stenosis, but that's not the only thing that can cause pain to go down the leg. There are other reasons for pain in the leg as well, and they can be coming from the joints, which we call facet syndrome. The facets are the joints of the lower back. A sacroiliac syndrome, which is in the pelvis, which can cause pain in the buttock or leg, and even muscle problems such as the muscle deep inside the buttock area called the piriformis muscle, which is commonly seen in runners, can actually pinch the sciatic nerve and create what we call a pseudosciatica, but nonetheless, it still causes pain in the leg. Next. So at this particular moment, just to get a feeling for how many people have disability associated with sciatica, this is a common tool that we use in clinical practice called an Oswestry Functional Disability Index, and it has a series of questions that help us understand how significantly sciatica or any particular type of pain associated with the back is affecting someone's livelihood, their function. So I want you to take a moment just to look at each question and kind of score it yourself. So for every one that applies to you, record 1 point. We're going to give you about 60 to 70 seconds to just add it up. And then I want you to write down the number or kind of remember the number. And I'll refer to this at the end again, just to help people understand how a functional disability score can affect how you feel and how your function is. So we're going to take a minute to just leave it up there so you can kind of take a look at it and score yourself. There's a series of 12 questions. For every one that applies to you, just give yourself 1 point. and go ahead and do it now. Okay, hopefully you've taken the time to add up that score, and we'll refer to this again towards the end of the webinar. Next slide. So I'm going to hand it over to Dr. Durkin now. He's going to talk about the different causes of sciatica, and then he's going to go into the different types of imaging that we can do to actually make the diagnosis. Dr. Durkin?
Thank you, Dr. Ben. So hello, everybody. This is my pleasure to be here today to talk about sciatica. As you can see from the slide, there are several causes of sciatica. Dr. Ben mentioned some of them before. If you could think of it as some type of irritation on one of the nerve roots in your back, that's a classic cause of sciatica. But there, outside of the spine, there's other causes that can cause things that are similar to sciatica, like Dr. Ben mentioned before. And those are the facet and sacroiliac joints, which are a little bit lower than the lumbar spine, or around the lumbar spine where the nerves are. Or you could have something in the buttock that's causing some type of spasm on the sciatic nerve as it travels down from the pelvis into the leg all the way down to the foot. So you can see the screen there. The first picture in the middle on the top is a very common cause of sciatic type of pain in older adults. Usually starts around the age of 60, and as we get older, unfortunately, the lumbar spine tends to wear out and degenerate and kind of collapse, and this may be a reason we get shorter as we get older. The disc will wear out. It's kind of like deflating a tire on a bike, and now that bike doesn't stand as tall. So what happens when the disc degenerates, then the bones start rubbing together, and we start getting arthritic problems within particularly the facet joints and in the bones in the back, and that can cause facet pain, which is a very common cause of low back pain, and it can cause compression of the nerves and limit the blood flow that gets to the nerves. Now that picture there is with a person upright. As we stand up and start walking, that space where the nerves travel, and I'm going to put a little arrow up here. You can see here is pretty normal. There's plenty of room around the nerves, and then we get down a little bit lower, and you can see the bones that are growing into the canal start to crimp those nerves, and that will cause back and leg pain, particularly when we stand up and walk. We go over to the next slide on to the right on the top. You can see another cause of sciatica could be a herniated disc. This can cause an inflammatory response and irritate the nerve root. This could be seen in people of all ages. I've seen patients in their teens who have herniated a disc and has caused sciatic pain, particularly athletic teenagers. This can happen, but this can happen throughout the entire lifespan and cause irritation on the nerve root. And an epidural steroid injection is usually a good treatment for that. The bottom picture in the middle, the facet syndrome, like I said before, the facet joints are a very common cause of chronic low back pain. It's just arthritis within the joints that articulate the two levels above and below in the posterior aspect of the spine. And I'm going to put the arrow there to show you the facet joint. And that's the joint there. Just a little to the left of the nerve root that you can see in yellow. We have treatments for that include injections and steroid injections and radiofrequency ablation, which I'll talk about in a few more slides. The bottom right slide, you can see the picture of the skeleton. This is the pelvis and hip area. And you can see that muscle called the piriformis, which helps us rotate our legs in and out. It attaches at the sacrum and at the upper part of our femur or our thigh bone. And in many patients, in some patients, the sciatic nerve actually pierces that muscle. And in other patients, it can just irritation in that nerve or in that muscle can cause irritation on that sciatic nerve as it travels out of the pelvis and down the leg and cause pain that goes down all the way to your foot. Another cause of this type of pain, back pain, that may radiate into the leg, into the lower extremity, may just be from muscle spasm. This happens all the time. I see this constantly in my practice, where somebody pulls a muscle in their back and it irritates the nerves that go down the leg and can mimic a herniated disc. These can be treated with some hands-on physical medicine or a needle into the muscle to inject some local anesthetic or perhaps some steroid or other substances that can help break that spasm and make patients feel better. Next slide, please. So how do you diagnose? Just like anything in medicine, we start with a history. We get a story about how this happened, and then a physical exam can help confirm our diagnosis. With the physical exam, after a physical exam is done, we may send you for testing with an X-ray or a CT scan or an MRI, which can help define where the problem is specifically oftentimes. And as you can see in the pictures in the bottom, that's an MRI of the lumbar spine. And you can see at the red dot there on the left image, this is coming at you from the side. I'm going to put a little arrow there. That disc is the L5-S1 disc, and that's herniated into the canal, as you can see where the red dot is. Now, the picture on the right is an image of the lumbar spine with a patient laying on their back with their belly at the top, and then their legs will be coming out of the screen towards you as you look at that. And that is a picture of the L5-S1 disc herniation, just a little to the left of the midline. And besides that, the facet joints look arthritic, which looking at the spine on the left looks like a middle-aged to older person with degenerative disc disease. You can see the discs from where my arrow is and the three above are fairly darkened. The disc at the very top on the left is a fairly good-looking disc. I'm going to put an arrow there. You can see there's a little lighter shade of gray. That means there's still fluid in that disc and it hasn't dried out like the ones below. When the discs tend to dry out, they have a tendency to herniate more. And then we kind of shrink a little bit, and then those bones in the big bones there, the vertebral bodies, where they join together, can be a common source of low back pain. And you can see in this patient here, they have some signs of inflammation in those end plates, what we call them. And there's a procedure for that I can speak about briefly on the next go around. So imaging helps confirm the diagnosis. I recommend getting imaging before having a procedure within 6 months of the time that you're seen by the physician. And this can help pinpoint the diagnosis and make our target more precise, and can help make your diagnosis easier and more precise. And that's it from me for here.
Okay, so I'm going to talk now, we're going to talk about different therapeutic procedures. We're going to start with what we call a stepped approach. We always start with the most conservative, non-invasive treatment first. And in our experience here at the Back and Neck Pain Center, typically we see that 78 to 82% of the patients that we triage and treat get better with conservative and non-invasive treatment. An additional 15 to 18% need to go on to some sort of interventional procedure that Dr. Durkin's going to talk about after me. But typically most patients respond to conservative care. So when we say conservative care, we generally offer patients the evidence-based treatments that literature has shown in studies to be very effective, and they include both physical therapy and chiropractic medicine procedures. Let's talk a little bit about physical therapy. So we offer at physical therapy here at Mather, we offer McKenzie therapy, which is a very specified procedure that uses directional preference. And what I mean by that is we try to find out if you have sciatica and it's going down your leg, for argument's sake, let's say it's your right leg, and we put you backwards into extension and that relieves your leg pain. You may feel a little more back pain, but your leg pain feels better when you go backwards. You have a directional preference for extension. That means going backwards relieves your symptoms. So a McKenzie therapist, like we have here at Mather, will actually do their therapy in extension. And you can see that on the picture at your very top hand left side, right here, this patient is being put backwards into extension. So the provider is holding the spine, the person's lifting up backwards into extension, and what she's feeling is a decrease in pain in her leg, and that helps to relocate the disc and relieve the sciatic nerve pressure. And that's called McKenzie therapy, and we're one of the few facilities that actually offer that therapy here at Mather. In the bottom left hand picture here, you can see that the physical therapist is actually developing core stability exercises. One of the things that always happens in people who have sciatica is they develop core weakness and stability weakness. We're going to go back a couple of slides to the MRI slide, and I want to show you something. So if you look at this picture right here, what we're looking at in this cross section of someone's back is this gray blackish material is the muscle. We should see that throughout the whole region of the lower half of that person's spine. In this particular part of the spine, notice how that's all white. What that represents is something called fatty infiltration. Fat has replaced muscle that is atrophied or weakened, and now has created a very unstable, weakened spine. So that can perpetuate problems and allow nerves to become inflamed. And unless you address that core stability issue and re-strengthen those muscles and get rid of that fat by replacing it with strong muscle, the problems recur over and over again. So that's an important aspect of core stability. And that's why whether you go to a chiropractor or a physical therapist, good spine care providers will always talk to you about regenerating those muscles by doing core stability exercises based on your ability level. And that can include using a big ball. Can you advance back to that picture, please? The next, yeah. So here you can see this person's working on core stability exercises. Now, for an older population, that may not be feasible. So there are ways to do this in the chair. There are ways to do this for older people that can't get on the floor and start doing sit-ups and core back exercises. But the mainstay of physical therapy and fixing lower back issues is doing core stability work and also doing McKenzie therapy. So chiropractors tend to do that as well. And then when we come to the chiropractic medicine side, this doctor at the top right-hand corner is performing a procedure in the lower back on a Cox table. So a Cox table is a table that actually goes up and down. If you look at the doctor's left hand, he's holding that portion of the table and moving the table up and down. And then his right hand is over a particular spinal segment or vertebrae. And when he pushes up and down, that tends to improve the facet or the joint mechanics to relieve pressure in the facet situation. And it also tends to decrease intradiscal pressure. So if there's a bulging disc causing the sciatica, it's almost like deflating a balloon. It's very non-invasive, it's very non-forceful, and most patients, if not all patients, can tolerate this procedure pretty well. The second thing that this table does is it actually moves back and forth. So this person's laying on the table, and the table's going back and forth, as you can see from those two red arrows, and it separates the spinal spaces, it decreases the intradiscal pressure, and what it helps to do is relieve pressure on the nerve to help relieve sciatica. Both of these are very, very successful procedures that I have used for years in my clinical practice, and patients with significant sciatica due to spinal stenosis or very large herniated discs do much better with these types of tables and techniques as opposed to the standard high velocity manipulation, or some people know it as the adjustment or the cracking manipulation, which can sometimes aggravate sciatica. So in my experience, this particular type of chiropractic medicine is more effective for the types of sciatica that have spinal stenosis and herniated discs. Next slide. So from a non-pharmacological point of view, the other things that physical therapists and chiropractors do is we talk to patients about not just exercise in the clinic, but also exercise at home. It's really vitally important if you want to prevent recurrence. And by the way, the incidence of recurrence for back pain and sciatica is 50% within 1 year and almost 80% within 2 years if you don't change your lifestyle. So when we talk about lifestyle, we're talking about exercise. So on the bottom right-hand picture, you can see that this particular person is walking, and sometimes that's really just all you need to do is just walk, maybe carry a water bottle, use that as your weight, and that helps to develop lower extremity strength, it helps to develop back strength, but also your diet. So when we talk about diet, we at the Back and Neck Pain Center and in our clinical practices, we always advocate using the Mediterranean diet, which is an anti-inflammatory diet, but very simply eating the rainbow. So if you look at this plate, very colorful, you have browns and greens and yellows. These foods are very high quality foods that have a lot of anti-inflammatory properties. We're not going to get into the biochemistry of that today, but picture this plate versus going to a fast food store and buying burgers, cheeseburgers, bacon cheeseburgers, fries, and milkshakes. Pretty much just one or two colors versus all these great colors that have a lot of nutrients that help to reduce inflammation. So in helping yourself at home, one of the most important things you can do, in addition to seeing a provider that can help get rid of your symptoms, is also eating better, more healthful, and also exercise. So those are non-pharmacological additions that we supplement to our clinical practices when we're treating you from a conservative particular point of view. Next slide. So I'm going to bring back Dr. Durkin. Dr. Durkin is going to talk about the role of medical treatment, from, as you can see, medications, but also he's going to talk about some of the expert interventional things that he does in his clinical practice. And he does a vast array of very many procedures, unlike most interventional procedure physicians that I know. He's got a lot of tools in his toolbox, and he's going to discuss some of them now.
Thank you, Dr. Ben. So, from a treatment standpoint, we oftentimes start with from a less invasive side before we get into more invasive things. But this might just get you a bridge until the time we can get you in for an injection. Some of these medications that are here work okay, but nothing's really that great. One thing we do try to avoid these days is opioids. 20 years ago, you might be given an opioid. If the slide was, we were doing this talk 20 years ago, the opioid might have been on the picture. And as we know, the opioids are not as good as we thought they were 20 years ago. So anti-inflammatories, whether it's in a pill form like the naproxen on the bottom right, or acetaminophen, which is a mild to moderate pain reliever, and over the counter, or to some type of gel like the Voltaren gel you see in the top left corner. These things can help alleviate some of your pain, get you more active. We may sometimes give you some a dose pack of steroids if we can't get you injected sooner than later. But for the most part, once you get into the Back and Neck Center, we can get you in for an injection within a week or so. These will be more of a bridge. Muscle relaxants are also sometimes given, which can help you calm down the muscles a little bit and get you more relief. The downside is some of these medications can make you sleepy, which can be a good thing if you have having a hard time sleeping at night. You take a mild muscle relaxant that can sometimes help you get some sleep for a few days. And then the injections here, you can see in the bottom left corner of the picture, you can see a needle going in to do what looks like a trigger point injection. And you can see these are not very deep. They're right below the skin surface and into the muscle, where we can sometimes palpate and reproduce the pain by pushing on that area, which is really the definition of a trigger point. And the next slide. This is what I specialize in, the minimally invasive treatments for back and leg pain. The procedure that's been around for 100 years, an epidural steroid injection, is usually the first line for sciatic pain or pain down the legs or pain from a lumbar spinal stenosis. And this involves taking a small needle into the spine, and we can go 3 different ways. We can go right in between the little bumps in your back, right in the middle. and get it to the level where the herniation is. We can do what's called the transforaminal injection, which comes from the side and gets along the nerve root. And this is more useful for more of a lateral disc herniation. Or we can come from the bottom with a caudal. And what I like to do is go in this way and slide a catheter up into the epidural space within the lumbar spine and inject right where the disc herniation is. And the mainstay of that treatment is to get steroid around where the disc herniation or stenosis is. Like I said, it's been around for 100 years. We do plenty of these at the pain center at Mather, and is very effective for at least for a short amount of time to get your pain under control. Facet blocks or ablations are done, and those are done for patients with facet arthropathy or facet pain. And you can see the facet joints, and there's one at each level up and down the spine on each side. And we target the nerve that goes to that joint. If we numb up a nerve that goes to a painful joint and the pain goes away, we can assume that's where the pain is coming from. We will oftentimes do 2 of these diagnostic injections. Also throw a little steroid on the joint also to get a little bit of a therapeutic effect. But the key is if we can diagnose the pain as coming from the facet joints, then we can ablate those nerves with a special needle, or we put the special needle on the nerve that innervates the painful joint, and that heats up to a temperature that burns away that nerve. That nerve will grow back, but it'll take anywhere between 6 months and 2 years to do so. And during that time before it grows back is when your pain is a lot better than it was before. The sacroiliac joint is a joint that's located a little lower. This would be half of the sacrum. This is the sacrum that you can see here. And the joint, the hip bone joins right here, and that space in between is a sacroiliac joint. Very common, maybe 25% of chronic low back pain comes from sacroiliac joint problems. And for that treatment, we will put a small needle into the joint, make sure we're in the joint with the x-ray machine, and inject some local anesthetic and some steroid. And many times you only need one of those, and the effect can last for quite some time. The key, though, is with the local anesthetic is to make the diagnosis. We get the needle into the joint, we put some local anesthetic in there, and if your pain gets better and you're able to move your leg around better, then that we can assume that's where that pain is coming from. Further treatment for that, if you only get short-term relief from the injection, is to possibly ablate the nerves that go to the joint, or something that we're doing now is where we are putting a little a dowel into the joint to fuse it. Actually did 2 of those this morning. So that's the sacroiliac joint. For spinal stenosis, lumbar spinal stenosis, where the canal in the middle of the spine is crimped down, like in the pictures we saw a few slides ago, there's 2 minimally invasive treatment options that we offer at Mather: the mild procedure and the Vertiflex procedure. The mild procedure stands for minimally invasive lumbar decompression, and that addresses a cause very common in folks as we get older, the ligamentum flavum, which you can see in the arrow I just put there, that green structure in the cartoon. That ligament has overgrown and caused the canal where the nerves go through to crimp down. And the mild treatment addresses that ligament. We put a small pencil-size introducer cannula into that area between the bones. And I'll show you in this view. We go right into this area here, and we chip away some of the bone and some of the ligament that's causing the stenosis. And that's done with a local anesthetic and a little bit of sedation. It's a little bit more invasive than an epidural, but not that much more. And it's a lot less invasive than traditional surgery on the back. Another option that, so the mild procedure, the first ones I did on Long Island were in about 2010. So that procedure has been around for about 10 years now. The newer option is the Vertiflex procedure, where we take a small spacer. You can see right here, there's an example of one. In the top right picture on the screen shows it placed in between those bones, and I'm going to put one in right now. So that guy would go in here. We make a small incision at the skin, We have a series of tubes that can hollow out an area, and we place this guy with its wings down and we crank it open. And what that does is it keeps that level from getting smaller. So it keeps that space from crimping down and making the stenosis worse. So that's the Vertiflex procedure. And I did the first ones on Long Island in about 2016, 2017 or so. And we do these at Mather just about every week. So these are minimally invasive treatments that are all done under local anesthetic with some sedation from an anesthesiologist. We have this group of board certified anesthesiologists that will take care of you at Mather, and we can avoid a general anesthetic, which comes with its own set of risks. So things that are done minimally invasive are the future, and we are in the future right now in the minimally invasive treatments for back and leg pain at Mather and Back and Neck Center.
Thank you, Dr. Durkin. We'll answer anybody's questions in a little bit. So just to go over quickly about the Back and Neck Pain Center here at Mather, let's just go over some of the principles of our practice and why they're important. So we practice patient-centered care, and essentially that means that we discuss all the diagnoses, keep you in the loop all the time, and we give you treatment options, and we make joint decisions together. The days of we telling you what to do are over, and that's called patient-centered care. Timely appointments, so when we determine that you need to see a guy like Dr. Durkin, you used to have to go through your primary care doctor, and then maybe an orthopedist, and it would take weeks on weeks to get an appointment to see someone like Dr. Durkin, mostly because you're going through channels of other providers. So when we make the assessment here at the Spine Center that you need to go to someone like Dr. Durkin for a procedure, we usually get you in within a few days, not a few weeks or months. And that's critical, because if the time period of getting someone in who has severe pain and needs an epidural, for example, and you're told you need to wait 6 weeks to get that epidural, that's almost cruel. So when we have someone in severe pain who has severe sciatica or leg pain, and we know they need an epidural, Dr. Durkin's practice is very accommodative, and he works closely with us here at the Back and Neck Pain Center, and we usually get you in there within a day or two, sometimes 3 days at the latest. So like I said before, we use a step-ladder approach to care. That means we start with the most conservative, least invasive first. That doesn't mean that if you're having severe leg pain and you've tried all the conservative stuff already, that we're not going to go through our ladder and get you to someone like Dr. Durkin more quickly. We are. Another concept is right provider, right time. That means if you come into us and you're having leg pain, and the leg pain is not really due to a true sciatica from a nerve being compressed, but it's caused by a joint, whether it's the sacroiliac joint or it's the facet joint. The right provider at the right time means that the literature and medical studies have shown, for example, that mechanical back pain, as long as it's treated properly right from the get-go, patients generally do pretty well with a chiropractor or physical therapist right out of the box. So we want to make sure we get you to the right provider. But by the same token, if you have a severe problem with leg pain and it's caused by a ruptured disc and you have other kinds of symptoms that we call red flags, the right provider may be a surgeon. So we may jump right to the top of the period if that's clinically indicated in your particular case. The good news is that's less than 2% of the time, so that doesn't really happen all that often, but it does happen. The other concept that we believe in here at the Back and Neck Pain Center is looking at risk factors, because as I said earlier, recurrent episodes of leg pain or back pain are very high within a 2-year period if you don't do anything to change what got you there to begin with. It could be due to you being overweight, you're not eating right, you're not exercising, you smoke. There are lots of different risk factors that perpetuate problems. And even if we put a Band-Aid on it, but we don't teach you how to change your lifestyle and change what you got, how you got there in the first place, it's going to come back one way or the other. As Dr. Durkin mentioned, we do not use high-risk pain medications. They're addictive, they don't really treat the cause, and they don't really fix anything. They're okay in the short term, but they're not okay in the long term, as we can all see through what's happening in the media with the opioid epidemic. And most importantly, we identify risk factors that can perpetuate pain, and then we manage them so that we can reduce recurrences in the future, so that most importantly, you can get back to living the life you want to, enjoying the things you love to enjoy, whether it be gardening, hobbies, golf, tennis, whatever it may be. Next slide. So here's just a schematic showing our step ladder. And on the very bottom, like we talked about, we start with the most conservative therapy, maybe a chiropractor or a physical therapist. And here at Mather, we have a great physical therapy department. But we also have, as the director of the chiropractic collaboration program, we have about 30 chiropractors who have been screened and vetted by Mather Hospital to be high quality chiropractors that we associate with. So if we determine and you determine together with us that chiropractic may be something you want to try and it might be good for you, we'll refer to a chiropractor associated with a hospital in your community. You can see that we'll refer to neurologists and orthopedists, but at the very top of the ladder is a spine surgeon. In our stats here at the Back and Neck Pain Center, only 2% of our patients per year go on for spine surgery. About 20% go on for pain management and interventional procedures with doctors like Dr. Durkin. Next. So I want to refer back to that outcome survey that I had you fill out, and hopefully a lot of you have filled it out. And I just want to give you a scoring summary. If you scored over 3, between 3 and 6 points, that means you have a moderate spine disability related to sciatica or back pain. If you scored over 6 points, that means you have a severe disability. And what that means in English is that functionally, the problem that's happening inside your spine is affecting your life, not just from a pain perspective, but it's affecting you from a functional perspective, and it's changed the quality of your life. We look at outcomes in our spine care practice here, and we measure how our interventions change someone's function and change someone's quality of life. And last year's survey of all the patients that we saw, over 70% of the patients, I think it was almost 76% of the patients we saw, said that we made significantly high improvements in the quality of their life by treating them and triaging them through the therapies that we offer here, and also increasing their patient quality of life through increased function of being able to do the things they like to do. So if you scored 3 or more in that survey, it behooves you to call us at the Back and Neck Pain Center. And that address, that email address that you see at the very top, that's the Back and Neck Pain Center's email address. So if you just jot that down, it's math-bnpc@northwell.edu. You can email me with any questions you might have. If you'd like to make an appointment, and if you scored more than 3, you should call this number, 686-2565. You'll get our central scheduling department, and we'll get you set up to see our nurse practitioner who will evaluate you, make clinical decisions. And one of the things that we didn't talk about that we do at the Spine Center, at the Back and Neck Pain Center here, is we have weekly interdisciplinary meetings, meaning that we look at every file and every patient from a team perspective. So we have an MD looking at you, we have a chiropractor looking at your file, we have a physical therapist looking at your file. So we have a very interdisciplinary look at your file, and together as a team, we decide where you should go, and then the nurse practitioner sits down with you and discusses with you, gives you the options, and we set you on your way. And again, like I said, care is timely because we have access to our specialists, and we get you in with where you need to go within days, not weeks. So again, if you have any questions, email me at math.bnpc@northwell.edu. And if you just want to make an appointment, go ahead and jot that number down. Feel free to call us. So we're going to open this up to questions now to see if there are any questions, and I'm going to hand it back to Emily.
Thank you, Dr. Benaliahu and Dr. Durkin, for your extremely informative presentation. If anyone has any questions, you may enter them in the Q&A feature on the bottom of your screen. What is the expected life of the Vertiflex system?
Well, it's a titanium implant. It should last forever. There are some complications that occur, but they're rare. I would expect that to last at least a few years. But it remains to be seen. It hasn't been around, for more than 3 or 4 years now. So I hope that answers your question.
What are the side effects of the procedures?
So there's side effects to everything we do in medicine, and we always have to weigh the risks versus the benefits. So anytime you put a needle through the skin, there's a risk of infection. I've had 2 infections in the last 15 years, and I've done thousands and thousands of injections. So that doesn't happen that often. You can have the biggest side effect I would say that we have is some pain after the procedure from doing the procedure itself. And then some people that have diabetes in particular may have their blood sugar elevate a little bit after a steroid injection. So those are things that we have to look out for. So every patient is different, and you know, a good physician will go over these side effects that could happen in that particular patient. So I tell patients, anytime you put a needle through the skin, there's a risk of bleeding and infection. So we make sure you're not on any blood thinners for certain procedures, and we make sure that you're not at risk for infection. And those things will be weighed against each other, and the right decision should be made in conjunction with you, the patient, and the physician that you're treating with.
Can more than one spacer be placed?
So 2 spacers can be placed at the same time in the contiguous levels. So that's how it's paid for. I have put in 3 spacers in a patient or 2, but that was at 2 different times. So you can have 1 level stenosis, 2 level stenosis, 3 level stenosis, and usually if we will take the 2 worst spaces first, and then reevaluate the patient several months later to see if a 3rd spacer may be needed to be put in if there is 3 level stenosis.
When is a spine stimulator recommended?
I didn't talk about spinal cord stimulation because it doesn't work that great for spinal stenosis. It does work really well for sciatic pain after a surgery in particular that hasn't worked, or if you're not healthy enough to undergo surgery, spinal cord stimulation is a good option. So spinal cord stimulation has been around for over 50 years, and in the last 5 years, it's really gotten the technology has gotten so much better over the last 5 years than it was for the first 45 years. So 10, 15 years ago, these stimulators would cause a tingling sensation over the area that hurt. Nowadays, we use oftentimes high frequency stimulation where you don't feel anything. Your body just responds by dropping your pain level. And there's many indications for spinal cord stimulation for back and leg pain or neck and arm pain. And these are things that we offer through the Back and Neck Center also.
How does chiropractic treatment differ from PT?
So that's a very good question. There's a lot of overlap between what chiropractors do and what physical therapists do. I'd say that if I had to differentiate the two, chiropractors get trained a little more in diagnosis and imaging. They tend to be more diagnostic related. For example, like I order MRIs all the time. I'll order other types of studies. But from a therapeutic level, physical therapists tend to be more based in exercise rehabilitation. So getting back to what I talked about before, from a core stability point of view, they'll focus a lot on core stability exercises and actually teach you how to train yourself at home. They'll do a lot of exercises in the clinic. Again, it depends on the provider that you go to. Chiropractors do that as well, but what chiropractors do that physical therapists don't is they utilize those specialized equipment tables that we talk about, which are more tractional tables. So in this particular condition that we're talking about, spinal stenosis, sciatica, whether it's due to spinal stenosis or a herniated disc, those tables done by chiropractors who have them, which isn't every chiropractor, so you have to go to the right chiropractor, they actually reduce the intradiscal pressure, and as I said, they restore normal joint function. In spinal stenosis cases, it creates a little more room to unpinch the nerve. So physical therapists generally don't have that type of equipment where chiropractors do, and physical therapists tend to do more exercise stuff. Both physical therapists and chiropractors use other modalities like ice and heat, electrical muscle stimulation and ultrasound, laser therapy, and both tend to talk about lifestyle as far as exercise, posture, and nutrition. But I'd say the main difference is, as I discussed, is the chiropractors that have those tables, physical therapists generally don't.
Are spacers even an option in a scoliosis patient with sciatica?
That's a good question. There is a certain degree of scoliosis that you can't go over. I believe it's 18 degrees. So it's not recommended over 18 degrees off the top of my head. It might be 19 degrees or something like that. But yeah, severe scoliosis is not an option. And you're better treated by a spine surgeon, perhaps, if injections don't help.
If anyone has any more questions, feel free to enter them at the bottom of your screen. There doesn't look to be any more questions. We want to thank you for joining us today. If you do have a question that you think of after the fact, feel free to email us at matherhospital@northwell.edu or the email that's on your screen to reach Dr. Ben directly. And we'll make sure we get the answer for you. Once you exit the webinar, you'll see a link to complete a survey. If you could please complete the brief survey, your feedback is extremely important to us. We want to thank you.
Sorry, Christine.
Yep.
Someone asked a question, can chiropractic and PT work together? The answer is yes. Years ago, there seemed to be some sort of competitive atmosphere between physical therapists and chiropractors. That's really not the truth, because as I said, there's significant overlap between what we do. If you're familiar with a Venn diagram, if you put two circles together, in the middle of the circle where the overlap is where chiropractors and physical therapists do the same thing. But the bigger part of the circles on the outside are physical therapists are definitely strong in some areas, whereas chiropractors are stronger in other areas. And in my experience, in my clinical practice, I work with physical therapists all the time because I know they're really good at things that help patients. So in the best of both worlds, you want a patient to have what's necessary to get better. So do they work together? Yes. Is it helpful to the patient? Absolutely. But again, it comes down to the providers you're working with, because the providers, both chiropractic and physical therapists, have to believe that. And people that do tend to get the best outcomes. Good question. All right, I want to thank everybody for attending today. Again, as Christine said, email us or call us with any questions. I want to thank Dr. Durkin for his expertise today. And I want to thank our staff, Christine and Emily, for doing a great job on running the Zoom webinar. Thank you, everybody, and have a great day.
Thank you.